Special investigations. Blood. Leukocytosis indicate inflammatory conditions. Its role in the diagnosis of acute appendicitis is considered very high. Besides this, it is almost always present in acute cholecystitis, acute pancreatitis, etc. Acute intestinal obstruction, when complicated by strangulation, may show presence of leukocytosis. Sugar and urea estimation of the blood are important. Diabetic crisis may mimic an acute abdomen. Uremia may present itself with persistent vomiting accompanied by increased distension of the abdomen to make this condition confused with acute intestinal obstruction in pancreatitis. The serum amylase estimation will be high. While the normal value is 80 to 150 Somogyi units, 400 units is considered to be suggestive presence of acute pancreatitis. The highest level of 1000 to 2000 units reaches within the first 24 hours, after which it may come down to normal. The serum creatinine calcium level is lowered in acute pancreatitis as calcium is fixed in the formation of soap. It may take 5 to 8 days after the attack. The fall in the serum calcium level is a good index of severity of acute pancreatitis. A level below 7 mg per 100 ml is considered to be dangerous. That is, the serum bilirubin level is raised in acute pancreatitis. The plasma fibrinogen is also raised in the end of the first week and should turn to normal within the third week. It is of considerable prognostic value. Straight X-ray showing multiple fluids levels shown by arrow and gas in acute intestinal obstruction. Gallstone analysis showing air in the biliary tree. Z. Serum deoxyribonuclease, leucine aminopeptidase (LAD) and lecithinase A may be raised and considered to be a definite diagnostic index so far as acute pancreatitis is concerned. Increased serum methalbumin indicates the presence of underlying hemorrhagic pancreatitis. Estimation of the C-reactive protein is important as high level of serum is considered to be diagnostic of acute appendicitis. C-reactive protein (CRP) is found to appear in sera of individual in response to various inflammatory conditions and tissue necrosis. This appears when the inflammatory condition subsides. A venous blood sample is taken for estimation of the CRP in plasma. CRP is estimated by extracting serum by configuring and determining the value of latex fixation test kit supplied by Ranbaxy India Limited. When CRP value is more than 6 mg per liter, this is considered significant to be diagnostic of acute appendicitis. Blood pressure. This becomes low in any hemorrhagic condition. In acute pancreatitis, where shock is permanent feature of the disease, the blood pressure will be lowered. Routine urine examination should be a must in any case of acute abdomen. In acute appendicitis, there may be presence of blood and pus cells in the urine due to approximation of inflamed appendix to the ureter. This does not indicate any disease of the urinary tract. Obviously, in renal colic, one may expect streak of hemorrhage in urine. Estimation of the urinary disease is an important laboratory test. In acute pancreatitis, the disease index may rise to 500 units or more from normal 110 to 30 units. Glycosurium may be present in acute pancreatitis. X-ray examination. Where there is facility, X-ray examination affords a distinct help in arriving at a diagnosis. In straight X-ray, multiple fluid levels and gas indicates an acute intestinal obstruction. Straight X-ray in sitting position, when show presence of gas under the diaphragm, it indicates perforation of the gastrointestinal tract. It is in suspected gastroduodenal perforation. 20 to 30 ml of air is injected into the stomach by means of rice tube and skygram is taken in sitting position. Gas under diaphragm confirms the diagnosis. Similarly, gastrographin may be used to mark the perforation. In acute cholecystitis, the bile duct may be visualized by intravenous cholangiography with bilirubin, but the gallbladder is not seen. If the gallbladder with the bile duct is visualized, it is not a case of cholecystitis. In acute cholecystitis, gas in the duodenum and first coil of jejunum is sometimes seen. Stewart's sign, that is, gas-filled hepatic and splenic fractures. No gas in the transverse colon is suggestive of this condition. Effacement of the renal and psoas shadow and the film of fluid between gas-filled ileal coils are additional evidence in favor of this condition. In case of intussusception, screening and skyography after a barium enema are of value in diagnosing the condition by showing pinch-shaped end of the barium enema. It also helps in spontaneous reduction of the intussusception. In suspected gallstone shadow of the stone near the termination of the small intestine will clinch the diagnosis. To differentiate renal colic from appendicular colic, intravenous pyelography is very important. In acute ulcerative colitis, a shadow of remarkable dilatation of the transverse colon, toxic megacolon may be seen. After perforation, free air within the peritoneal cavity may be noticed. Barium enema examination. This with air contrast may be helpful in detecting the early stage of the acute ulcerative colitis. Barium röntgenographic signs include loss of hostile markings and irregularities of the colonic wall, which represents small ulceration. As the disease progresses, pseudopolyps become prominent. When there are clinical signs of toxic megacolon, barium study is contraindicated. In Crohn's disease, double contrast barium study may reveal longitudinal and transverse mucosal ulcers or fissures. May present as spicules. In the irregular network of intersecting ulcers combined with mucosal edema to result in coarse nodularity or cobblestone pattern. There may be filling defects due to hyperplastic lymph follicles. The hallmark of this disease is presence of skip lesions with apparently normal intervening bowel, which may measure a thick inch or to several feet in length. Barium enema examination of the diverticulitis shows segmental spasm of the serrations, sawtoothing of the bowel. Mucosal edema and the narrowing of the lumen may be evident. It cannot be overemphasized that barium enema examination is absolutely contraindicated in very acute conditions. This examination, however, may be performed when acute condition has subsided. Endoscopy. Proctosigmoidoscopy is helpful in acute ulcerative colitis as the rectum is involved in 90 to 95%. The mucosa is usually edematous and granular and bleeds easily. Superficial mucosal ulcers are seen. In Crohn's disease regional enteritis, endoscopy reveals cobblestone appearance with deep linear ulcerations. Colonoscopy will determine the extent of the disease. In ulcerative colitis and in Crohn's disease, skip lesions become evident. In very acute diverticulitis, sigmoidoscopy may be painful. Mucosa is inflamed and diverticula may be seen, but narrowing of the colon, spasm, fixation, and angulation are more commonly seen. Note the pincer-shaped ending of the barium enema of the the pathognomic feature of intussusception. Enema. Indiscriminate administration of the enema in acute abdominal conditions must be strongly condemned. Nothing is more harmful than an enema given in a case of peritonitis. The only suitable subject for administration of an enema is one of the acute intestinal obstruction. In this condition, the two enema test is of greater value. The first enema may show some result by evacuating the lower bowel. It is the result of the second enema given after an interval of 2 hours that lead to the diagnosis. In the presence of obstruction, the fluid of the second enema is either retained or rejected without any fecal matter. The patient is not relieved. Intravenous cholangiography permits visualization of the entire extrahepatic biliary tube though this investigation was used earlier for acute cholecystitis, as oral cholecystography is contraindicated and now it is losing ground in this condition. Ultrasonography. This non-invasive imaging technique has become the routine investigation in acute cholecystitis. It demonstrates gallbladder calculi, bile duct calculi, dilatation of the gallbladder with stone and sludge stone in the cystic duct, dilatation of the biliary and even a tumor in the pancreas. Ultrasonography is a significant tool in diagnosing appendicitis. The overall specificity and sensitivity was found to be 90% and 88% respectively, giving USA a high specificity and sensitivity value in diagnostic appendicitis. It also helps in diagnosing other causes of right lower quadrant pain. Radioisotope scanning. Cholecystography with 131 iodine rose bengal or with the derivative of technetium-99 immunodiacetic acid. Technetium IDA scan has become more specific test than any other in acute cholecystitis. After intravenous injection of this material is excreted in the liver excreted by the liver into the biliary ductal system. This shows the extrahepatic biliary tree including gallbladder. In acute cholecystitis, the gallbladder is not visualized as presumably the gallbladder outlet or the cystic duct is obstructed. It has an accuracy of almost 100%. Computed tomography CT scan, it provides almost similar information as ultrasonography. It is probably useful for those in whom ultrasonography is difficult. That is, example in obese patients and in those having excessive bowel gas. Exploratory laparotomy. On many occasions, acute abdomen, the diagnosis is not established until a laparotomy is undertaken. Causes of acute abdomen. Intra-abdominal causes. Inflammation. Example: acute appendicitis, acute cholecystitis, acute salpingitis, acute diverticulitis, acute gastrointestinal acute regional enteritis, acute pneumococcal peritonitis, acute non-specific mesenteric lymphadenitis, amoebic liver abscess, perforation of the peptic ulcer, typhoid ulcer, diverticular disease, and ulcerative colitis, etc. Acute intestinal obstruction, mechanical, in the lumen, gallstone, narrow gallstone, round worms, fecolis, etc. In the wall, tubercular stricture, intussusception, growth, etc. Outside the wall, additional bands, volvulus, external and internal hernias, etc. Toxic, paralytic, alias neurogenic, hispunk disease, vascular occlusion of the mesenteric vessel by embolism or thrombi, hemorrhage. Example: rupture of the ectopic gestation, ruptured lutein cyst, spontaneous rupture of the malarial spleen, rupture or leak of aortic aneurysm, aortic dissection aneurysm, torsion of the pedicle. Example: twisted ovarian cyst, spleen, etc. Colics. Example: biliary, ureteric, appendicular, and intestinal. Extra abdominal causes, parietal conditions. Example: superficial cellulitis of the abdominal wall, gas gangrene of the abdominal wall, abscess of the abdominal, rupture of the rectus abdominis muscle, and tearing of the inferior epigastric artery. Thoracic conditions. Example: diaphragmatic pleurisy, lobar pneumonia, spontaneous pneumothorax, pericardial angina pectoris, coronary thrombophlebitis, etc. Thrombosis, etc. Retroperitoneal conditions: uremia, pyelitis, Diddle's crisis, retroperitoneal lymphangitis, and lymphadenitis, leaking aneurysm of the aorta, dissecting aneurysm of the aorta, etc. Disease of the spine, spinal cord and intercostal nerves. Example: POTS disease, POTS, osteomyelitis of the lower dorsal or lumbar vertebra, gastric crisis in tabes dorsalis, herpes zoster of lower intercostal nerves, and intercostal neuralgia. Generalized disease. Example: malaria, typhoid fever, prophylactic diabetic crisis, sickle cell anemia, hemophilia purpura, smallpox, etc. In children, the following conditions are common: acute appendicitis, intussusception, intestinal obstruction by roundworms, congenital band or by bands, including Meckel's diverticula, acute non-specific mesenteric lymphadenitis, Meckel's diverticularis, primary peritonitis. In females, the following conditions are common: ruptured ectopic gestation, ruptured lutein cyst, twisted ovarian cyst, acute salpingitis, tuber ovarian disease, torsion or degeneration of the uterine fibroid.